would like to start by thanking on behalf of my co-authors the organizing committee for providing us with the privilege to share our data in the plenary session. And I have to add that I feel really small talking after so many real, huge, practice-changing phase 3 trials. And I have to confess that what I'm talking about in the next 10 minutes will not change your practice tomorrow. However, I hope that it will help to revive the interest in the development of CAR T-cell therapies for acute myeloid leukemia. This will be about a first-in-class, switchable, allogeneic, chimeric antigen-receptor T-cell for CD123 positive AML. These are the results of the phase 1A dose escalation part of the REF***123 study. I think we can all agree that autologous CAR T-cells have transformed the way we treat non-Hodgkin's lymphoma and multiple myeloma today. However, development of CAR T-cells for acute myeloid leukemia has been far more challenging due to a variety of reasons, including intrinsic and therapy-induced T-cell functional impairments frequently seen in this disease. In addition, it's really hard to identify a suitable target antigen, which is clean and allows for safe immune targeting. CD123 is a potentially interesting target antigen in AML because it's expressed by the majority of patients and not only on more differentiated leukemic blasts, but also on the putative leukemic stem cells. However, it is also expressed on healthy hematopoietic progenitors. So targeting with a conventional CAR T-cell might come with the risk of long-lasting aplasias. We took a rather unconventional approach by starting with an allogeneic T-cell derived from a third-party healthy donor, which circumvents the problems of an impaired autologous immune system. However, this requires a few genetic modifications. We first CRISPRed out the TCR locus to prevent GVHD. We deleted the whole MHC class II locus to prevent host CD4 T-cell rejection. And we selectively removed the HLA-A molecule to prevent host CD8 and NK cell rejections. That leaves us with HLA-B and C in place, for which we have to match our donor T-cells to the patient's HLA haplotype. The REF-CAR is an inert second-generation CAR, which does not recognize any target antigen in the human body. Instead, it carries a universal adaptive peptide on its surface, which serves as the target for our RTM123 targeting module, which is basically a bispecific antibody. This connects the REF-CAR T-cell to the target antigen CD123 on the surface of the AML cell, activates the T-cell and lyses the AML cell. This is a small molecule, and due to this small size, it has a short half-life, which requires continuous infusion over 24 hours a day. This, however, also provides us with a safety switch. We can switch off the infusion whenever this is necessary due to safety concerns. And we can switch it on again if needed. In addition, an allogeneic product comes with the advantages of off-the-shelf availability and scalable production because you can use a single healthy donor leukapheresis to generate multiple batches of REF-CAR T-cells. We included adult patients with relapsed and refractory or MRD-positive AML without available standard of care treatment options. CD123 expression was required on at least 20% of the patient's leukemic blasts. Of course, patients were required to have an adequate performance and organ function status, and as I said, they had to be matched for HLA-B and C alleles with the donor batches. The primary objective of this phase 1 trial was the determination of safety and tolerability, and of course we wanted to describe the nature and severity of dose-limiting toxicities, and to identify a maximum tolerated and/or recommended phase 2 dose. Secondary objectives included clinical activity, the pharmacokinetics, and as well as immunogenicity. Patients received standard lymphodepleting chemotherapy using fludarabine and cyclophosphamide for 3 days. They received a single dose of REF-CAR T-cells on day 1 in conjunction with the start of the RTM123 continuous target molecule infusion, which lasted for a total of 21 days. Dose escalation was first guided by a Bayesian optimal interval design, guiding us through the escalation of these two components, RefCAR-T and targeting module. Thereafter, we followed the 3+3 design. The target module was switched off after 21 days of infusions, allowing patients and T cells some rest, and we used this period to assess the response. In those patients deriving benefit, we allowed repetitive re-stimulation rounds with infusions of RTM123 for a total of 12 days each cycle. Please note that we did not apply any second RefCAR-T cell doses so far. These are our patient characteristics. Altogether, we included 17 patients with a median age of 63 years. All patients had either intermediate or adverse risk profile according to ELN 2017 classification. The median number of prior treatment lines received was 4, and 65% of the patient had received at least one prior allotransplant. The dose escalation was pretty smooth, so we moved quickly from dose level 4, escalating the target module, then escalating the T cell dose, and then continuing with another escalation step of the targeting module. We reached dose level 15 without formally defining a maximum tolerated dose and declared dose level 15 the provisional recommended phase 2 dose based on the totality of the available safety and efficacy data. Let's come to the primary endpoint first. This is our safety profile. Overall, we found this compound to be quite manageable. We did see cytokine release syndrome, however, it was of low grade in the majority of patients. We didn't see a single case of ICANS, no GVHD, and there was one case of IEC-HS, which qualified as a dose-limiting toxicity and occurred at the highest dose level. This was managed by using anakinra, dexamethasone, and pulling the on-off switch. We did see the expected cytopenias with some infections associated. However, there was no treatment-related mortality. I would like to illustrate the functionality of the on and off switch with one of the patients treated at our hospital. This is a 43-year-old heavily pretreated AML patient relapsing after 2 allotransplants. He was given a single dose of RefCAR-T cells on day 1, and at the same time, we also started the targeting module. And you can see a steep increase in the RTM123 peripheral blood levels, given in green here. Already 24 hours after we switched on the system, the patient developed grade 2 CRS, accompanied by a steep increase in serum IL-6 levels. As this was poorly controlled by standard of care measures, we choose to pull the trigger and stop the infusion, which led to a rapid decline in RTM123 serum levels, which was later followed by a decrease in IL-6 and a resolution of the CRS grade 2. We decided to switch the system on again seeing a CRS grade 2, again switching off the infusion, again seeing symptoms resolving and IL-6 going down. After that, the patient continued to the rest of the 21-day infusion period without any remarkable events. Cytopenia was seen with this regimen, as can be expected. I'm showing here the neutrophil count courses for all the patients treated, and if you look at the average, you see that we have a dip after the lymphodepleting regimen and during the RTM123 infusion, but generally this is reversible. The same applies to platelets and to erythrocyte counts. Let's have a look at the expansion. Well, we did see quite a decent and, in that extent, unexpected expansion of the RefCAR-T cells. At dose level 15, we had a median expansion over 160,000 copies per microgram DNA, which by far exceeds the levels we've seen with a previous autologous product using a similar technology. And it also exceeds the levels you can find with some of the CD19-directed autologous T cells currently used in the clinics. RefCAR-T cells showed persistence. If you look at all patients, the median persistence time was 43 days, and at the highest 2 dose levels, we had 5 out of 8 patients with persistence of more than 30 days. Let's have a look at the responses. Overall, we saw 4 responses in 12 evaluable patients. At the highest dose level, there were 3 responses, including 3 CR/CRh, including 2 CRs with conversion to MRD negativity. In addition, we had one patient with morphologic leukemia-free state and one patient converting for MRD positivity to MRD negativity. These responses tended to be durable, at least at the higher dose levels. As you can see here, there are several patients that received repetitive rounds of stimulation with RTM123. In conclusion, I hope I could show you that our first-in-class switchable allogeneic CAR T-cell targeting CD123 has a manageable safety profile. We did see unprecedented expansion and persistence for an allogeneic CAR T in the AML setting. And I think we can consider the activity seen thus far as promising. Therefore, this trial will continue into its phase 1b part, now enrolling 20 additional relapse and refractory AML patients at dose level 15. With that, I would like to thank the patients, their caregivers for participation, of course, all my co-investigators at various sites in Germany and the Netherlands. I would like to thank the sponsor AvenCell and the great team there doing a really great job in running this study. And of course, I would like to thank you for your kind attention, and I will be happy to take your questions.
So this paper is open for discussion. Maybe I can start actually. You mentioned that your wave CAR T are persistent. I wanted to know whether the persistency is actually also related to whether or not you inject this TM activator.
Yes, it probably is so. You need to activate these T cells and you need to reactivate them to have long-term persistence. So at the moment, we don't have too much data for those patients stopping the trial early due to progression, so we can't really comment on what happens if you just give one round and then leave the system on its own. But I would expect if you don't stimulate the CARs, you will lose them at one point. But the beauty is that you can play with the system. You can switch it on, you can switch it off, you can prevent exhaustion, you can add additional targeting modules which are easy to develop as they're just bispecific antibodies.
I see a question on microphone.
Sam Riding from Bonn, Germany. Thank you very much for this beautiful data. Quick question, how many of these 4 complete remission patients were transplanted? Because as you mentioned, you have included more than 50% patients that have been transplanted, which is great.
You mean how many had received a prior allotransplant, or how many?
4 complete responding patients. How many of these 4 were transplanted?
I don't recall from the top of my head. I can just tell you that 2 of these were treated in my institution and both had received an allotransplant before. If your question is more on the question how many received an allotransplant afterwards, at the moment we don't have anyone receiving an allotransplant, but of course that's an option for those patients relapsing at some point.
Thank you.
Thank you. I think microphone 4, yeah?
This is a question about the nature of the relapse. How many of the patients recruited were in molecular but not clinical relapse versus clinical relapse?
Yeah, very valid point. We only had a single patient recruited in the MRD positive setting. All the others were over hematologic relapse.
And microphone 6, please.
Hi, David Bishop from Westmead Hospital in Sydney, Australia. Thanks for a really interesting presentation, very interesting concept. I really understand why you wanted to use allo cells, but my question is, when you use the bispecific, and this might come from preclinical data, was there a benefit that was clearly derived by having the bispecific attached to a CAR on the T cell as opposed to something like CD3 that would be there on your allo cells as well as any native T cells?
Yeah, well, first of all, to the autologous native T cells, there I think we run into the problem of having an impaired T cell system. So you can reconnect them to the AML cells, but it's hard to reactivate cells. And if you look at the data we have for bispecifics in AML, I mean, you see some responses, but they're usually not very long lasting and not occurring in the majority of patients. In terms of whether we can use simply allogeneic cells and add a bispecific T-cell engager, well, that's certainly something we cannot answer with this trial, but my personal guess is that the beauty about the system is that you can equip the allogeneic CAR T-cell with additional features such as co-stimulatory molecules, and you can induce a prolonged persistence by knocking out recognition sequences for T cells in the recipient's body.
Okay, thank you very much. I think we need to conclude, so I'd like to thank again Dr. Wermke.